Welcome to everybody who's on the call. It's my pleasure to introduce Patrick Tarpey, who's the solid cancer clinical scientist lead for the East Genomics Laboratory Hub. Patrick, I've known quite a long time, and has, as well as being a clinical scientist, Patrick worked at the Science Centre on the Human Genome Project, and has worked in the last few years on the 100,000 Genome Project, looking at cancers in various patients, and was in the press 2 weeks ago. Many of you may have seen that he was in the press in the Times and the Guardian, and I think in the Daily Mail, I think, and produced some work on paediatric cancers and whole genome sequences. So Patrick's been asked to talk to us about how we're using genomic data in cancer care, and really important for histopathology because it's the tissues that you're producing that allow Patrick and his team to do their work. So over to you, Patrick.
Thanks a lot, Colin. So, okay, I'll just dive straight in. I presume you can see my slides.
Yeah.
Okay, so yeah, I guess the purpose of this talk is just to give a brief overview of the GLH and what the scope of the GLH is, what the aims are, what it needs to do, and the purpose behind that endeavour. So generally the GLHs are being set up to try and improve efficiency across cancer and rare disease. And they've been, the way to improve that efficiency is to divide the country into 7 genomic laboratory hubs with a lead centre in each hub. And these centres become the focus of genomic testing within their regions. And the overall aims, therefore, are to try and derive consistency and equitable care across the whole country. So all the GLHs are in coordination with each other, and they all operate using similar guidelines, albeit different protocols sometimes. However, the aim is to provide equitable care irrespective of where you are within the country, whether you're associated with a big hospital or a small district hospital. You can get the same access to sophisticated tests because you're part of a wider GLH. So with respect to histopathology, pertinent to this talk, this necessitates material, and that material necessitates the activity on the screen now. So cutting sections and slides and making assessments on the purity of those slides, so that when we perform our assays, we can be confident that the starting material is appropriately suitable to inform and to give us confidence in the readout of the assays that we pursue. So GLHs are intimately linked with the test directory. So the test directory is an online resource, which is a bit like a menu of tests. Each test, in this case cancer, each cancer test has got a specific code. You can look it up on Google Test Directory, and you can see a rather dull Excel downloads, and it looks something like this on the screen here, where you have a clinician can use this as a guide to order tests that GLHs should be able to deliver. Now, the reality is that in the cancer test directory, there's 1,000 tests, and in the East geography, there's 10 million people. So to be able to deliver all those tests for all those people is an evolution as opposed to an absolute, next day delivery sort of service. So this is a necessary work in progress. We work with our partner hospitals, Nottingham and Leicester, and we strive to deliver these tests to as many people as possible and to therefore improve cancer care to the patients within our region. So the bar chart here shows a depiction of the test directory with respect to the clinical indications that are present therein. So it's divided into these 4 cancer types: neurological tumours, sarcomas, solid tumours, and paediatric solid tumours. And the size of the bars and the numbers indicate how many distinct tests are pertinent to each of those clinical indications. Another way to view those with respect to what we can do and what we can deliver is to look at the types of variants that are required to deliver those clinical tests. So that's what this second bar is. So there's 1,000 different clinical indications that require some sort of assay. The reality is that there are the same sorts of genes or loci interrogated in more than one test. So ultimately what a GLH has to do is to deliver about 200 distinct targets. And those targets may be different classes of variant, structural variants, small nucleotide variants, methylation, copy number variants, whole genomes. If you can deliver all those, then you have access to all the clinical indications within the test directory. So what we aim to do is to increase our repertoire of tests to deliver that ask. So what I'm showing on the slide here are the variants which are small nucleotide variants, and the graph on the top shows how the genes that the test directory mandates one pursues with respect to this class of variant. The height of the bar indicates the number of clinical indications that are resolved by that gene. So the highest one on the top left here is BRAF. So there's about 15 clinical indications where interrogating small nucleotide variants in BRAF is a test directory deliverable. We've got an assay in-house that's just about to come online called TSO500, and it delivers 65 of the 72 distinct genes that can deliver the 200 or so SMV test directory indications. So that's a reasonable assay for that test. Other indications we need to pursue are structural variants. So that's indicated on this slide here. We need to deliver 429 clinical indications. There's 79 distinct genes. The first three are NTRK 1, 2, and 3, which are promiscuously mandated across many test directory indications. Hence, they're high on the y-axis there. And the assay that I referenced earlier, the TSO500, it does okay, but it doesn't do brilliantly to deliver this class of variants. So it delivers 34 of the 79 genes. There are other assays depicted on the slide here, Archer and Illumina PanCam, that do a better job. So we've got an STP trying to deliver the one on the right there, the PanCam, which would deliver 76 of the 79 structural variants. So all this is developmental activity ongoing to try and deliver the ultimate aim of the best possible service for the test directory and other indications even outside the test directory. Copy number variants are depicted on this slide. There's 223 clinical indications. The assay that we have available is pretty poor. Actually, it only delivers a quarter of the test directory indications for copy number changes. So again, we need alternate means to interrogate this class of variant if we're going to deliver the test directory in its entirety. So there's lots of work to do to deliver. In reality, the most pertinent test that we have available to us, and that's driving the majority of change, is whole genome sequencing. So whole genome sequencing, as depicted on this slide, comes in different flavors. So the first panel indicates whole genome sequencing, sequencing the entire cancer genome. In the middle panel is whole exome sequencing, where we extract just the coding sequence from within the cancer genome and sequence that, and that gives efficiencies in that it's much less sequencing that one needs to pursue, albeit it's a bit more complicated to extract those exons out in the first place. And on the right-hand panel is capture, which is a smaller component of a whole exome. So the reality is an exome is 22,000 genes. Within the cancer genome, there's about maybe 800 to 1,000 cancer genes in total. So the most discrete assay is to do a capture of just those cancer genes of interest. Within the historically, NGS services within HODS has been constrained to a hotspot panel, and that's depicted in this red box, the referral form that indicates those tests. Going forward, there'll be we're improving this assay and adding additional assays to improve the historical service in ways that I'll describe going forward. So the assay that was available in HODS for many years, the PGM assay, has been replaced with two of these nice machines here shown on this slide. These are called Genexus machines. So it's the same technology, albeit updated. And this is a really good clinical workhorse because it enables access to those DNA hotspots, but it also brings in other classes of variants like copy number changes and gene fusions. So it adds additional content of value to the test directory. It's also a nice machine for a clinical environment. There's very little preparation of the sample required before you can utilize this machine. So that's a real advance, and the whole level 6 has been under Colin's supervision, has been rearranged and developed to enable this capacity, this machine and other machines like this to sit within a newly refurbished building, which is really, you know, an excellent resource generally. In addition to that resource, we have opportunities. So that kind of replaces what was there before, does it a bit better. In reality, what we need to do is to do many more genes than is depicted on that panel, and we need to extend beyond hotspots to whole genes. So with a tumor suppressor gene, we're interested in looking at every base within that gene, as opposed to an oncogene where we might be focused on discrete hotspots. So the assay that is just pending live services, this assay depicted on this slide, a TSO 500 assay, as the name suggests. There's about 500 cancer genes resident on this panel. So we take our genome, we chop it up, and we fish out the coding sequence of these 500 genes. And they are interrogated on, again, these two nice machines shown at the bottom of the slide there. These are NovaSeq 600, so top of the range Illumina chemistry, and they have massive capacity. So they are future-proof and fit for service to deliver large numbers of genes to large numbers of people. And there are other assays that are under development, which are non-NGS. So shown on the slide here is an array that informs the methylation profile of a tumor, and that can be very informative when trying to secure a diagnosis based on the clustering pattern of a particular tumor and how that relates to legacy data that already populates a global resource that is available for this test. And yeah, I think finally, and maybe the assay that I'll focus on much today is whole genome sequencing. Shown on the slide is a SERCOS plot now, which depicts the whole, or all the variation from the entire genome of a cancer sample. And this is available currently to certain indications, but will become much more prolific as the GLH matures, and there'll be much more opportunity for patients to access the most informative singular test of a whole genome sequence. So all that development is ongoing, and that's all necessary and useful and helpful. But in reality, we shouldn't forget that it requires an awful lot of work upstream and downstream of the actual shiny machines and the data produced. So pertinent to this call, obviously we can't do anything without good FFP specimens or fresh frozen specimens. So all those pathways to deliver that to the GLH are really important. And then those other steps depicted in that process, so extraction of the DNA and RNA, the library prep, sequencing, variant calling, informatics, there's all infrastructure necessary to deliver that in an efficient way and improve on legacy activity and legacy resource, for example, LIMS, which are not really used to be able to do complexity and real high volume. So there's lots of work to do around the actual assay itself to make this a deliverable service. So why is sequencing the driver of this activity? Well, the reality is that it's a flexible tool that can deliver different classes of variant. So when we do a sequence using next generation technology, if you're not used to this sort of technology, all it requires is us to take DNA, chop it into small fragments, and then we sequence a small part at the ends of those fragments. So typically a fragment might be 400 base pairs, and we'll sequence 100 base pairs of either end of that 400 base pair fragment. And there'll usually be a gap in the middle, and that's very valuable because that allows us to see if there's discordance between how the first and the second read within any given fragment presents. So for example, they could map back to the genome to different chromosomes, and that would suggest that we've sequenced over the breakpoint of a translocation. Similarly, the sequencing reads themselves, the end bits are very important because that gives us the actual data, the actual reads within our tumor sample, and we can see if how they are aligned to the genome and if there's any mismatches that inform the presence of a variant within those sequences. So whole genome sequencing allows the opportunity to identify all these variant classes in a single assay, really. So point mutations, small indels, large deletions, whether heterozygous or homozygous, amplifications, which can be frequently targeted, the target of oncogenes, or translocations. This is what they look like in real life. So this is just a depiction of a tumor sample at the top and a normal sample at the bottom. On the left-hand side, we have the presence of a germline substitution present in both tumor and normal. On the blue here, we have the presence of a somatic substitution exclusively present within the tumor sample. So not inherited at birth, acquired during the lifetime of the cell in which it resides. So if we can look at substitutions, a whole genome gives us this clarity to look at other classes of variant also. So what I'm showing here is a depiction of the entire genome of a tumor sample. On the top here is an arc that indicates a translocation between chromosomes 2 and chromosomes 9. And in the bottom, in the middle and in the bottom, these are assays that inform the copy number changes resident within this tumor sample. So we can see where we've got chromosomal gains and chromosomal losses, and these can be very important to inform the diagnosis or prognosis and potential therapeutic opportunity for patients. Just another example of real data, in this case a translocation. What we're seeing here is real reads, so these are the 100 base pairs that we sequenced. We've got a dotted line here that indicates the breakpoint position between a translocation, and the colorful stuff is the presence of the sequence on one chromosome. It's colorful because it doesn't map it properly to where it's trying to map here. And the right-hand side maps perfectly in gray because that's the appropriate, the second chromosome in this fusion hybrid molecule, which maps appropriately to this region of the genome. So within these data, we have tools to be able to examine these classes of variant, and we can also, by viewing the data, get a real good feel for the validity and the integrity of what we see, so that when we present these data at an MDT, we can be confident that we're presenting something valid and not something that's likely to be artifactual. So the somatic mutations that we pursue are of value because they can inform the clinical opportunity for the patients. So very briefly, where did they come from in the first place, and what do they look like within a cancer genome? Well, when we are conceived and we're just a fertilized egg, our genomes are pristine and bereft of any somatically acquired variation. But as we grow, as our cells divide, copying those 3 billion base pairs, it's protected by numerous mechanisms to ensure that no mistakes are made, but nevertheless, minor infidelities escape those protection mechanisms. And that manifests as a somatic mutation in the daughter cell. But this isn't the problem because most somatic mutations reside within an inconsequential region of the genome, probably non-genic, or even within a gene that's not pertinent to cancer. So the problem arises when depicted in this early clonal expansion, there's a sort of cog-shaped somatic mutation. This one is slightly different. This one has been acquired by chance within a cancer gene, and it's changed the behavior of that cell relative to the behavior of its neighbors. So it's conferred a growth advantage, which means that that cell can proliferate. And via that proliferation, it may acquire additional somatic mutations in additional important cancer genes that further accelerate that cancer growth, ultimately into allowing it to convert into an invasive or a metastatic cancer. So when we look at a tumor, we're looking at the end stage here. So we're looking at a catalogue of somatic variants, the vast majority being benign, not playing a role in the development of the cancer, a small number being causally implicated in that cancer development, and they're called drivers. and maybe even some that are ultimately confer resistance to treatment, albeit not only when that treatment's provided. So we look at this concatenation of lots of different classes, lots of different variants, and what we try and pull out is clarity. So clinical clarity, the driver variants, the causal variants, and then from there we try and identify if any of those causal variants provide clinical opportunity for the patient. When we do a paired genome sequence, so there's two different ways that we can examine a tumor sample. One is via a paired analysis, where we co-sequence the tumor with a normal tissue from that patient, usually blood if it's a solid tumor, or more usual for panel-based FFP testing, we only have a tumor sample. So in that case, our analysis options are in some ways more limited. But if I explain what goes on when we sequence a tumor for whole genome sequencing, that will illustrate what I mean from this. So when we sequence a whole genome, we get normal sample and a tumor sample. These dots are supposed to depict the variants that we identify when we sequence these genomes. So we'll identify variants in both normal and tumor, and those variants will be small variants, copy number variants, structural variants, or even whole chromosome gains and losses, cytogenetic changes. And the germline allows us to identify those variants which are unique to the tumor and therefore somatically acquired, because those will be usually the variants which drive the development of that cancer in the first place. So they're the variants which might provide opportunity for therapy. The germline variants themselves are, however, still important. So they can reside in three classes, essentially. They're either benign, the majority will be, or they're pathogenic, in which case it may be that they've been responsible for the development of the cancer and there's a family history potentially, so we can explore those variants in other family members. Or they may be, we won't be able to interpret them, they're of unknown significance. But nevertheless, the advantage of a genome is that we get clarity with respect to germline variants because we sequence a normal sample. If we exclude the germline variants, then we're left with only those variants which are acquired within the tumor sample, and these can be again of two flavors. Those variants which are passengers, like I've just described, which are just benign, they are just acquired during normal the cell's exposures or cell replication, or drivers, so those variants which have been implicated in cancer development. So the drivers are clearly important because they're the things that make the cancer grow. So by targeting those driver variants, we may be able to offer a therapy to reverse the growth of those cancer types. So when we look for drivers, that's the first step. Then the next step is to determine if they're actionable. So actionable may mean that they are informative for therapy, but it also might mean that they enable they're informative with respect to deriving a diagnosis or providing prognostic information. Or they may be simply non-actionable, albeit causally implicated in cancer development. The passengers, therefore, one would think that they don't add much value, but in reality, they do add clinical value. The number of passenger variants, the overall tumor mutation burden within a cancer sample, can give some information as to how well that cancer would respond to immunotherapy, for example. The other reason that they may be informative is that those passenger variants may coalesce into a distinct signature or fingerprint that will give some insight into the past exposures of the tissue that is under investigation. So if I flesh that out on this slide here, what I'm showing is a graph at the top where we have lots and lots of different cancer types depicted by these acronyms here. The dots is a particular cancer of that particular cancer type. And going from left to right is the increasing mutation burden within those cancer types. So if we go to the extreme left here, this is a skin cancer. And the bar at the top is mainly red. So these bars indicate the types of mutation that are present in melanoma skin cancers. So in this case here, they're mainly C to Ts. And when we plot that with a bit more resolution, in this plot here depicted signature 7, And the resolution is enabled by looking at the base before and the base after the mutated cytosine in this case. Then we can generate a profile that looks like this. It's 96 bars long, and these C to Ts resolve in this particular context depending on the trinucleotide sequencing context. So this is a signature that is characteristic of UV light. So that's entirely consistent with what we might see in a melanoma. And when we perform similar experiments in other tissues, we can see that alternate signatures present in different tissues. So signature 7 at the top is our UV light signature. That's very different to the signature 4 here, which is the signature of a lung cancer. So lung cancers are mainly have a signature consistent with C to A mutations. So the carcinogens in tobacco smoke leave an imprint of C to A mutations on lung tissue. An alternative way to get a signature is when there's defective DNA repair. So as I mentioned, cells have mechanisms to try and protect themselves from accruing error, but sometimes those fidelity mechanisms are compromised, and they may present in a specific signature. So signature 3 here is consistent with a BRCA mutated breast cancer. And that's clinically important because that is a treatable cancer. There's a therapy, PARP inhibition, which has been efficacious in cancers that look like this. Historically, one has needed a BRCA 1 or 2 mutation to be able to appropriately suggest that that's the right course of treatment. But in reality, as these signatures become more robust and secure, it's likely that these treatments can be conveyed just on the basis of these passenger mutations, these discrete signatures. The final one at the bottom here is a colorectal cancer, again, with a very distinct signature, 2 big spikes that is caused, again, by a defective polymerase in this case. So is WGS beneficial over other genome tests? I've got some data here from a small study that we did for our 100,000 genomes screen. And within this screen, what we sequenced was, this is pediatric cancers exclusively. So we sequenced 2,000 cancers altogether. So 36 of those pediatric. This pie chart indicates the types of pediatric cancer that we looked in. So mostly CNS, and the depictions around this, the bottom indicate this precise types of CNS cancers. So MB medulloblastoma, EP ependymoma, for example. So we sequenced 36 cases from 23 different tumor types. And what was the net effect of sequencing those data? And when I refer to the net effect, I'm referring in over and above any standard of care treatment or opportunity that may have been available for those patients. So what we see is a great big green part of this pie chart here, which means that of all the reportable variants that we've seen, most of them were novel compared to standard of care. So this in it of itself illustrates the value of a really expansive test. So either whole genome or a very large panel, we can derive variants which are reportable, have some value, which wouldn't be derived by normal current standard of care testing. One example of that is shown on this slide here. This is a mutation called tandem duplication. So on this region of chromosome 7, this bit in green here, that is traversed by these 2 genes, ZNF394 and BRAF, was duplicated in our tumor sample. And the region where the breakpoint of that duplication resides brought together these 2 genes in a functional orientation, which meant that this BRAF gene became constitutively active. So it was driving this cell to grow, even in the absence of an external stimulus, under the normal control that this gene normally functions against. So ideally the sort of variant that we're looking to try and identify within these cancer types that we sequence, because when we have an activated oncogene such as this, then there's opportunity for a targeted therapy to focus exclusively on the cells containing this activated oncogene and cause those cells to die. So we can have focused therapies against activated oncogenes rather than the generic chemotherapies that may otherwise only be available to patients. Very single slide summary of that 36 cases shows that in some of the cases in the left-hand side here, we were able to change or modify the diagnosis. So in 6 cases, we either changed or modified the diagnosis by having a full genome view of the data. So that's quite a big thing. That's, you know, the useful outcomes. Obviously, securing a diagnosis, which may have been equivocal, is very important because that informs the appropriate treatment regimen downstream from that secure diagnosis. In the middle here is indicating that 20% of the variants in this study were prognostically informative, and a similar amount, about 20%, similarly conferred opportunity for therapy. Now, it might be that they weren't required therapy. It might be that the patient responded well or that there was surgical intervention. Nevertheless, if patients relapse, it provides our clinicians with opportunity that they would not have otherwise in the absence of this big expansive test like a genome. We have that was from our 100K data, and we are pursuing this in real time now, in real commission service. We've sequenced about 58 cases so far. These are data from 50 of those cases. All this pie chart showing here is that what we do is to ensure the validity of this whole genome test. We compare our results to standard of care tests, whether they be a standard of care test that has resulted in a negative result, such as FISH, IHC, or some targeted assays, or a standard of care test that's resulted in a positive result, FISH, IHC, NGS targeted. So we keep a very close eye on the performance of our WGS to ensure that there's no anything to be concerned of. Again, this purple stuff here shows the stuff that wouldn't be pursued by a standard of care. So these are all variants which provide novel opportunity. There is a small suggestion of discordance here compared to standard of care, but in the most part, these reflect imperfections in the available sample rather than imperfections in the pursued assay. So very briefly, I'll just now end with a few case studies that give some sort of context to some of these global generic observations that we've shown thus far. So what I'm showing here is all the cases that we have looked at for 100K and for our live service, 100K in red, live service in blue. The axes indicate the increasing substitution or indel burden on the X and Y axes, and the diameter of the circle indicates the increasing burden of structural variants. So these graphs give a kind of insight into whether a sample is really quiet, has very few variants, or is very busy, has lots and lots of mutations. So in reality, what we're interested in is outliers such as these ones, which are very, very hypermutated. So why are these hypermutated in that way? Slides have gone haywire. Okay, so I'm just going to focus on this one at the top here to start off with some just case examples. So there's 3 cases here with elevated TMB, tumor mutation burden. 2 of them derive from the same ependymoma specimen. So we'll just consider one of those cases, and the other is a glioblastoma. So looking at these 2 cases, another way to depict just how different they are to every other case is on these tree maps at the side here. So if we present every case, now our 60 or so cases, as a box with respect to how many substitutions they have, we can see that this glioblastoma has this massive, massive box compared to the ependymoma in red, and in grey, all the other samples that we've sequenced. So it's really unusual to get a cancer with 1 million mutations like this one has. With respect to other classes of variants, indels, the ependymoma and the glioblastoma, these 2 tumors look pretty similar, but they're still vastly different to all these other cancers. So there's something going on in these cases. When we look at the data in more detail, we can resolve what's happening in these cases. So both of these cases have got what is termed congenital mismatch repair deficiency. So the mechanisms that the genes that protect the genome from repair, from mutation, so these DNA repair genes, In these cases, they've been compromised, so they've been mutated. So a net effect has been the accrual, a massive accrual of lots and lots of mutations, because the cancer cells have lost this surveillance mechanism. And in the first case of the ependymoma, that was caused by 2 mutations in PMS2. So this is a DNA repair gene. So it's unusual to see 2 mutations within a gene such as this. So that's why we're seeing this young presentation of a brain tumor in a child. It's frequently seen as a single mutation in colorectal cancer in adults. In these 2 children with these 2 brain tumors, it's biallelic, it's on both alleles. And the MSH, the purple stuff, this glioblastoma with this massive excess of subs, is conferred by 2 mutations in MSH6. So why has the glioblastoma got this massive excess compared to the ependymoma when they've got the same essential diagnosis? Well, this was resolved by a friend of mine who I worked with in the Sanger Center, Adam Schlein, in 2015, who looked at outliers such as this and noticed that when there was a massive outlier such as that glioblastoma, there was also an additional mutation in this gene called poly. And this is another one of, this is a polymerase, so it copies DNA. And within this polymerase, there's a region that confers a proofreading functionality, so an error correction. So in this cancer type that we have here, and in other mutations with poly variants, when there's a mutation within this proofreading domain, then the polymerase is unable to repair error. So on top of the already compromised mismatch repair deficiency, this cancer's also got a defective proofreading capability, and that's resulting in this massive, massive excess of variants. So clinically, that's valuable because A, we've found germline variants which absolutely need pursuit in parents and other family members. The hypermutator in CMMRD for the first case was suggestive of a CMMRD phenotype. So if we didn't find both PMS2 mutations, it would still be likely that one resided somewhere. And in the ultra hypermutator, the pattern is so unusual that it's diagnostic of CMMRD with or without the variants being present. But the advantage of whole genome is we would usually see the variants that confer that anyway. My second case here is one of Sam Bajati, one of the oncology colleagues' case. And this is a case of a neuroblastoma. So neuroblastoma is a rarish tumor that fewer than 100 children diagnosed in the UK, mostly before the age of 5. Albeit rare, it's still one of the most common solid childhood cancers outside of the brain. In neuroblastomas, the synopsis for patients is they can either simply just regress without treatment, or they can be incredibly aggressive and essentially lethal. So the difference between those prognostic outcomes are informed via the data. So they're informed via certain amplifications for specific genes or by certain copy number changes. So the 2 black arrows on the right here are 2 of those copy number changes which we seek in this particular cancer type to inform the prognostic outcome. And unfortunately, in this case, this is a signature of a poor prognosis for this particular patient. Nevertheless, the genome delivers this information with absolute clarity. So in the absence of a whole genome, there'd be an array of different assays required to interrogate all those classes of variants. So it'd be a sequential series of assays which the whole genome can supersede in a single test. In addition, the thing that makes this case interesting is that there was a germline panel applied over these data, which was negative, but the genome delivered a germline variant which was of interest. So a potentially controversial variant, it was in a gene called PALB2. The data to indicate that this is related to neuroblastoma is divided. So even locally, that opinion about whether this was contributory to the development of cancer is divided. Nevertheless, what's uncontroversial is that this variant confers a risk in adults to developing breast cancer. So this was a female patient. On the observation of that mutation, that this altered the treatment of that the radiologists provided to this patient here. So the tumor mass was within the chest area. And because of the presence of this PALB2 germline variant, the radiologists avoided breast tissue in their treatment options to not deliver any additional risk to those tissues which are compromised with a PALB2 germline variant. So that's an example of a real case where the genomes delivered a variant that wasn't delivered via other assays that was potentially of very importance to this patient's future. The second case here is a 13-year-old who presented with diagnoses, symptoms consistent with the presence of a brain tumor. Substance scanning did identify a brain tumor. The exact class of that brain tumor was somewhat controversial. It was either one of these two things on the screen here, a papillary glioneuronal tumor or an astroblastoma. The genes in parentheses would be able to resolve both of which one of those it was. So we looked at those within our whole genome data, and we didn't find any of those variants at all. The histology, since this is a pathology talk, I felt compelled to put on a pathology slide, irrespective of the fact that I can't in any way interpret it. But the pathology itself was consistent with an astroblastoma. And there was other assays that we have available to us to try and understand exactly to derive the diagnosis with clarity, such as a methylation array profile. But in this case, it was uninformative. The tumor distributed in a way that didn't suggest it was any of the known cancer types within the legacy data. So when we screened this sample, we found a quite busy tumor, busy with respect to structural variants. The weird thing in this case was that all those structural variants were constrained to between chromosomes 17, 19, and 22. So this massive complexity within these defined chromosome regions provides opportunity for this cancer cell to generate variants which may be beneficial to its growth. And that's exactly what we've seen. We've seen a fusion involving an MN1 gene and a gene called GTSC1. If you remember, MN1 was one of the genes we were originally looking for in this case. So to see a fusion involving this gene and broken in a similar way is very suggestive that this is a novel causal gene consistent with this being an astroblastoma. Unusually in this case, we've seen another fusion, unusually because you don't often see two fusions within a cancer sample. However, it was so deranged that there was opportunity for two fusions to present. This is a bona fide fusion which is seen in some sarcomas and increasingly in CNS tumors. And when we redid the methylation profiling and included some samples that had this novel fusion, this EWS PATZ1 fusion, our cancer type now clustered with other EWS PATZ1 fusions. So in this case, we were able to secure the diagnosis with certainty via this MN1 fusion and also identify why the clustering of the cancer seemed aberrant in the first case, in this case. This patient's cancer was resected. The importance of deriving the diagnosis in this case is that astroblastomas are more aggressive and more likely to relapse than the alternate diagnosis. So this patient, albeit well, is now having increasing surveillance than they'd have had in the absence of this mutation. So I'm going to end that quick fire exploration of the cancer genome there by just saying that genomic testing is expanding incredibly rapidly within the NHS via genomes, via panels, via accessory assays, which are necessary. And this includes NGS and these other assays. WGS is the most informative single assay. So on this site, we're big fans of this assay because we've seen how it evidentially delivers advances to patients. So Cancer Service will generally improve via access to these data, but absolutely critical. And I was just speaking to Colin this before the talk, these molecular assays are dependent on the upstream pathways, including the pathology pathways, so that we can appropriately access the volume of samples and the correct samples and the correct quality samples to make these tests suitably informative. So on the basis of us being intimately linked with pathology, I would offer a sincere thanks to everybody engaged in that activity on this call. And I'll leave it there.
Thank you, Patrick. Fascinating talk. And all I can say is I've heard Patrick speak on many occasions. And I think every time I listen to him, I learn something new, because I think that's how fast the the science is expanding and the clinical application. Is there any questions that anybody wants to post in the chat room or themselves? Hang on a sec. Oh, right. So John has asked.
Asking on behalf, perhaps, of
the trainees, John, yeah?
So, yeah, I mean, again, Colin and I were just speaking about this before. The aspiration is correct. So we need to improve our assays so that we can improve what we can offer to patients. And there's new drugs coming on the market all the time. So for patients to access those new drugs, they need access to the tests that that enable them to determine whether they can access those drugs. So what we need to do is to improve and to do lots more tests. So the GLH itself has got, a relatively discrete number of excellent scientists that is delivering this stuff thus far, but it's just going to snowball and catalog and to expand over time. So we're doing small number of genomes at the moment for certain cancer types. Waiting in the wings are breast cancers and ovarian cancers and colorectal cancers, common adult epithelial cancers, which will have add an avalanche of ask to the GLH. So what we need, I think, is to think how we can most effectively deploy our workforce and utilize the staff that we have available to us to be able to deliver this service. So working intimately with pathology seems to be one, a sort of a no-brainer in that ask. So all that insight into the cancer types themselves. So John and Jim, for example, attend our meetings and have a massively active part in the analysis. Their pathology insight is hugely valuable in informing the consequence of the variants that we look at. So when there's a pathology information that is consistent with the genomic information, then those things support each other to allow us to interpret the data more effectively. So pathology expertise in cancer genomic services, I think, is hugely valuable, and we'd be really keen to engage with anyone who's interested in being more involved to that end.
Thank you, Patrick, and thank you, John. Great question, and I think it's something that I've picked up since I started, that histopathology is on the verge of two major developments. One is digital pathology, and the second one is what genomic data we can get. And just as we've developed immunohistochemistry, I think this is the next step, and it's an order of magnitude above histochemistry, immunohistochemistry. Next question. Could you talk a bit more about how the results are going to be reported and then integrated with the pathology findings, i.e. putting the results in the context of the diagnosis and other prognostic features? Or does this happen at the MDT, which obviously is generally speaking, a specific MGT? So the GTABs are a particular type of MDT.
So yeah, I think compared to legacy practice, we have this new kind of meeting to ensure that we provide appropriate context to the variants that we present on a report. So for whole genomes, every whole genome goes to an MDT. So the way that works currently for pediatric and for sarcoma, for example, and for heme is, for peds and sarcs, it's a bolt on to the end of the normal clinical MDT. So all the appropriate expertise is still in the room from that meeting. And then we can present the molecular data distilled from a report where we've tried to bring out the clarity, the clinical clarity, so we don't tease through the whole genome, every single variant. We provide a distillation following some pre-analysis that scientists and pathologists have done prior to that MDT. So that's a very valuable engagement. The MDT adds clinical context, and there's frequently additional expertise within the MDT itself that can inform the validity of the observations that we see. Currently, those whole genome reports go into EPIC as a singular report, a dedicated genome report. The integration of that into pathology more generally, I would defer to one of my pathology colleagues as to what the appropriate mechanism to do that is, or whether it's necessary.
I'm happy to take that one on. This is Jim, by the way, if anybody doesn't know me, one of the pathologists. Yeah, I think for the genomes that they're so complicated and there's so much data that there really isn't any way to do it outside a bespoke GTAB. And also you've got germline data in there as well, which also has to be discussed and actioned. So I think for the foreseeable future, the genomes will all go through GTABs. I think when you're coming to smaller samples like kind of fusion panels or big SMV panels, I think perhaps in the early stages they might go back to GTABs as well. But I think eventually there will be something that the report will go back to the pathologist and that they'll sort of integrate themselves and then present at the standard MDT. I mean, in the medium term, we may not have separate GTABs. I mean, I set the sarcoma one up specifically, as Patrick said, so that it would be part of the MDT with the same staff there. I think that's very important, because there were discussions initially of having like a pan-cancer GTAB. I don't think that would have been the way to go. I think this eventually will just become part of a standard MDT process. But yeah, I think in the early stages, the small panels will come back to us as pathologists to integrate at MDT, and the genomes will stay within, or very complex findings on the panels will stay within the GTABs. That's how I envisage it panning out. And we're also going to introduce a system where there's a molecular lead in each subspecialty. So I'm going to be giving a talk to the consultant body in a few weeks' time. I'll put an invite out for that, where we'll kind of discuss some of these issues a bit more, appointing molecular leads for each subgroup. So they would probably be the first point of contact for complex findings. But if they still weren't happy to take them forward, then we would refer them to an appropriate GTAB.
Thanks, Jim. Okay, well, it just remains for me to thank Patrick. That was a fantastic talk, Patrick. And as I say, I learn something new every time, because that's the pace that it's actually moving at. And I think while I'm here in histopathology, I will be encouraging much more joint working with the GLH and how we can start looking at cancer diagnostics across the whole pathway. So thank you very much once again, Patrick. Fantastic talk. Thank you.
You're very welcome, Colin.
Thank you.
you.
Bye, everybody.
Patrick.
Bye.